I'm Dr. Ginay from the Department of Radiology, Nepal Medicity Hospital, and today we are going to discuss very briefly about venous mapping that we do in our upper arms whenever we plan for any patient to undergo AV fistula or arteriovenous fistula creation. So in AV fistula, what we do is basically join the two vessels with one another. The artery and the veins are joined, maybe end to end, maybe side to side, maybe end to side anastomosis, but whatever we do, we just join the artery and vein together so that the vein starts having a arterialized flow or high velocity, so that we can connect two needles of the dialysis machine and can have high flow in the dialysis machine, and so that it can act as a supplement of the kidney. But before we make an AV fistula, we need to make sure that the arteries and veins of that patient is good enough for any fistula preparation. So what we can do is we can do fistula creation at the level of the wrist, which is usually a radial artery to cephalic vein, radial artery to radial vein fistula, or also known as radiocephalic fistula. And we can do is brachial artery to cephalic vein fistula, also known as brachiocephalic fistula. We can also do a brachial artery to basilic vein fistula, also known as brachiobasilic fistula. Most commonly made fistula, the first fistula that a patient undergoes is a radiocephalic fistula, approximately 2 cm proximal to the crease of the wrist. So what we do is, before a surgeon makes those fistula, we need to map or do an ultrasound scan to see whether the veins and arteries are normal or not. For that, we need to understand that these are done usually for the assessment of maturation. So once you have undergone a fistula creation, we will check whether the fistula is being maturing or not, whether the venous end of the fistula is receiving the arterial flow or not, and that is what we do. If in case after a session of dialysis or after creation of fistula, patient develops a papular mass, swelling or swollen arms, we check whether is there any breach in the continuity of the vein, or is there any leakage at the site of fistula creation or not. So those are also an indication. To understand those fistula creation, we need to understand that the basic anatomy of the arteries and the veins of the upper limb. So this is cephalic artery. It changes its name at the level of the axilla, becomes an axillary artery. At the level of the upper arm, becomes a brachial artery. Then divides into ulnar artery and radial artery, and later on in the hands they develop a dorsal or palmar arches. And basically the three arteries that are very important are the brachial artery, the radial artery, and the ulnar artery. There are other variations that does exist. If you need to remember one variation, it should be a high trifurcation of the brachial artery above the level of the elbow. And in such cases, this high trifurcation has a risk of delayed maturation or development of juxta anastomotic stenosis as well. So if you do a mapping, if you are planning for AV fistula creation, make sure that you know whether your patient has a high trifurcation of brachial artery or not. Then high brachial artery trifurcations are very important, in the same as I already said. So there are three types of three methods through which a patient can undergo dialysis. The first and the most important, most easiest thing is the creation of an arteriovenous fistula. Sometimes the veins are not mature, you don't have enough length of the vein. In those cases, you can have an implant or PTFE implant, which are called arteriovenous graft. And then if nothing is feasible, you can have a central venous catheter put down into your jugular vein. Nevertheless, the most important, the most easiest, the most preferred is always the arteriovenous fistula, followed by arteriovenous graft, followed by central venous access. If it is in case of a dire emergency where you don't have time for the fistula maturation to be awaited and you need dialysis very quick, tomorrow maybe, then you could have a central venous access, or also known as tunneled catheter, permanent catheter, or something like that. And it is important to understand that arteriovenous fistula has a very long duration of sustainability. They can sustain up to 7-8 years if taken care of well. Whereas arteriovenous graft usually do not withstand more than 1.5 years to 2 years of duration. However, PTFE grafts or venous graft can be used in a shorter duration of time. They do not require long time for the maturation as arteriovenous fistulas. Arteriovenous fistulas can be created in two ways: a surgical method as well as